Thank you for answering the pretest. I am Dr. Kim Martin Tolentino, a PPS-STC member and pediatric cardiologist. Welcome to Please Be Careful with My Heart, an online CPD on congenital heart disease. The objectives of this lecture are the following. First, to diagnose the more common congenital heart disease in both acyanotic and cyanotic lesions. Second, to discuss the initial management in children with congenital heart disease prior to referral. And last, to properly refer children with congenital heart disease to a pediatric cardiologist. Congenital heart disease is an anatomic malformation of the heart and or its vessels which occur during the first few weeks of fetal development. Congenital heart disease are among the most common single group of congenital abnormalities with a prevalence of 8 out of 1,000 live births. Approximately 0.2 to 0.3% of neonates have symptoms during the first year of life. Hence, the diagnosis of congenital heart disease can be established in about 40 to 50% by the first week of life. And by the first month, about 50 to 60% of patients are diagnosed with congenital heart disease. In most cases, the etiology of congenital heart disease are unknown. Inheritance is multifactorial in about 90%, including genetic or chromosomal malformations such as trisomies like Down syndrome. Various environmental insults include maternal exposure to infection, diabetes, teratogenic drugs such as alcohol, lithium, exposure to radiation, low oxygen tension, or chronic hypoxia. Acyanotic heart diseases may be classified into two groups: left to right shunts and obstructive lesions of the left ventricular outflow tract. Left to right shunting will lead to increased volume overload, while the obstructive lesions will lead to increased pressure work. Atrial septal defect accounts for 6.4 out of 10,000 live births and around 7 to 10% of congenital heart diseases. There's a higher prevalence for female patients, and the natural course is benign, and these patients remain asymptomatic during childhood. These are the following types of atrial septal defect. Secundum atrial septal defect is the most common type, accounting to 50 to 75%, and it is located at the site of the fossa ovalis. A primum atrial septal defect is due to an anomaly of the endocardial cushion defect and is located inferior portion of the interatrial septum. This may be associated with cleft mitral valve and tricuspid valve anomalies. Sinus venosus occur in about 10% of all atrial septal defects. This defect is located in the entry of the superior vena cava in junction to the right atrium. With the presence of an interatrial communication, a chronic left to right shunt imposes a volume overload on the right-sided cardiac structures and results in dilatation of the right atrium and right ventricle. The direction and volume of blood flow across the atrial septal defect depend on the size of the defect and the relative compliance of the ventricle chambers during diastole. Spontaneous closure of the small secundum atrial septal defect may occur in the first year of life to as late as 4 years of life. A moderate to large atrial septal defect may be symptomatic between the second to third decade of life. Anatomic changes include right atrial and right ventricular enlargement and dilatation of the main pulmonary artery with subsequent tricuspid and pulmonary regurgitation. Long-term effect of increased pulmonary blood flow will result in pulmonary hypertension. Eventual reversal of the flow with right to left shunting producing clinical cyanosis has been described as Eisenmenger syndrome. The pertinent physical findings include a grade 2 to 3 out of 6 systolic ejection murmur at the left upper sternal border, with a fixed and widely split second heart sound. An ECG may be normal or may present with right axis deviation, incomplete right bundle branch block, an RSR pattern, or right ventricular hypertrophy. A chest X-ray may show mild right atrial and right ventricular enlargement, dilated main pulmonary artery with increased pulmonary vascular markings. Although the volume overload of the right ventricle is well tolerated for many years, the incidence of pulmonary vascular disease, right ventricular failure, and atrial dysrhythmias increases in the third and fourth decade of life. As right ventricular compliance falls, the left-to-right shunting decreases, and eventually, with the onset of severe pulmonary vascular disease, the shunt may reverse and cyanosis results as Eisenmenger syndrome. The average lifespan of patients with untreated atrial septal defect is up to 50 years of age, with most patients succumbing to congestive heart failure. Approximately 14% of unrepaired atrial septal defect in adults will eventually develop Eisenmenger syndrome. These patients present with cyanosis, dyspnea, fatigue, arrhythmia, chest pain, headaches, dizziness, syncope, and henoptosis. Subsequent morbidity include congestive heart failure, pulmonary thrombosis, and stroke. Patients with significant left-to-right shunting with right ventricular enlargement will require repair either by surgery or by device closure. Medical treatment with oral diuretics may be given for patients with symptoms of heart failure. Patients with secundum atrial septal defect with adequate septal rims are the only candidates for device closure. Ventricular septal defect. Ventricular septal defect is the most common type of congenital heart disease, occurring in 25% of the time. The patient may be asymptomatic or may present with congestive heart failure, and this depends on the size and the presence of pulmonary vascular resistance. The following location may be inlet, perimembranous, subarterial, or muscular. The most common type of ventricular septal defect is the perimembranous ventricular septal defect, occurring in 75% of the time. Patients with small ventricular septal defect may be asymptomatic. However, those with moderate to large ventricular septal defect may present with signs of congestive heart failure. The following physical examination include low body weight, dynamic and bulging precordium, harsh hollow systolic murmur at the left lower sternal border, asystolic thrill, parasternal lift, normal to increased second heart sound. An apical mid-diastolic murmur may be seen due to relative mitral stenosis. A small ventricular septal defect is usually asymptomatic due to its restrictive physiology. This may present as a high-pitched, short systolic murmur. However, for those with moderate to large ventricular septal defect, may have symptoms of heart failure with elevated pulmonary artery pressure. A hollow systolic murmur may be heard at the left parasternal border, and a systolic ejection murmur may be heard at the pulmonic area. The basic workup for a ventricular septal defect include an ECG, chest X-ray, and 2D echocardiogram. For patients with small ventricular septal defect, the ECG and chest X-ray may appear normal. However, for those with moderate to large ventricular septal defect, left ventricular hypertrophy may be seen. In those with severe pulmonary hypertension, Right ventricular hypertrophy may be seen in both ECG and chest X-ray. This chest X-ray is from a patient with a moderate to large ventricular septal defect. This shows cardiomegaly with increased pulmonary vascular markings. Small ventricular septal defects may close spontaneously in about 30 to 50% of the time during the first year of life. They may be asymptomatic. Those with moderate to severe types of ventricular septal defect may have symptoms of congestive heart failure with recurrent lower respiratory tract infections. Patients may eventually develop infective endocarditis. Some would develop infundibular pulmonary stenosis or aortic regurgitation. In 2 to 7%, VSD may develop with concomitant aortic valve prolapse. Pulmonary hypertension secondary to pulmonary vascular obstructive disease may eventually develop into Eisenmenger syndrome. A ventricular septal defect with a moderate to large size will usually need medications to alleviate the heart failure, and these includes diuretics, ACE inhibitors, and some form of inotropes. Surgical repair is indicated for those with symptoms and with a pulmonary to systemic blood flow of more than 2:1, presence of aortic valve prolapse. For those with pulmonary hypertension, surgery will be done after evaluation with the hemodynamic studies. Medical management for ventricular septal defect include medications such as diuretics, inotropes, ACE inhibitors. Nutritional support is also indicated. Surgical repair includes PA banding or pulmonary artery banding, which is a palliative procedure to control increased pulmonary blood flow, and corrective surgery by ventricular septal defect patch closure. Patent ductus arteriosus. This accounts to about 10% of congenital heart disease. Majority are seen in premature babies. This may be associated with congenital rubella. Manifestations may be asymptomatic to congestive heart failure depending on the size and PVR. A patent ductus arteriosus has a connection from the descending aorta to the pulmonary artery. Systemic blood flow is shunted from the aorta to the pulmonary artery, and this increases the pulmonary blood flow and eventual blood flow back to the left atrium and left ventricle, producing volume overload. Clinical presentations include tachypnea, feeding difficulties, diaphoresis, and failure to thrive. Patients may have recurrent respiratory infections, mostly pneumonia. Clinical presentation of PDA. Patients will present with wide pulse pressure, bounding pulses. They may have dynamic precordium. They have a classical, continuous machine-like murmur at the left upper sternal border. They may have a soft to increased second heart sound. An apical mid-diastolic murmur may be seen in patients with relative mitral stenosis. An ECG may be normal in patients with a small patent ductus arteriosus. For those with a moderate to a large PDA, left ventricle hypertrophy and combined ventricular hypertrophy may be seen. Likewise, an X-ray may present as a normal finding for those with a small patent ductus arteriosus. Cardiomegaly may be seen in those with moderate to large PDA. Dilatation of the main pulmonary artery with increased pulmonary vascular markings are the usual findings. This chest X-ray shows cardiomegaly, prominent main pulmonary artery with increased pulmonary vascular markings. A patent ductus arteriosus should spontaneously close during the first month of life. They may be asymptomatic. For those with large defect may present with congestive heart failure. Through time, patient may develop pulmonary vascular obstructive disease with eventual Eisenmenger syndrome. Medical closure of the PDA for preterm infants may be done using indomethacin, paracetamol, or ibuprofen. Patients presenting with heart failure may be given diuretics, inotropes. Device closure may be done also. Surgical treatment includes ligation and transection. This presents the different types of device closure, which include the use of coil and the use of a device. Obstructive lesions include the following: pulmonary stenosis, aortic stenosis, and coarctation of the aorta. Pulmonary stenosis occurs in 5 to 8%. This may be associated with congenital rubella, Noonan and Williams syndrome. The following types may be valvar, subvalvar, supravalvar, or peripheral. They may be asymptomatic unless with severe lesions. With pulmonary stenosis, the right ventricular pressure increases over time, leading to right ventricular hypertrophy. Physical examination include right ventricular lift, a thrill, systolic ejection click. A harsh systolic ejection murmur at the left upper sternal border may be heard that may radiate to the back, with a soft second heart sound. An ECG may have right axis deviation, right atrial enlargement, and right ventricular hypertrophy. A chest X-ray may be normal, but there may be a classical finding of a dilated main pulmonary artery, which is called post-stenotic dilatation. The natural history may be mild, patients may be asymptomatic. Through time, for those with severe lesions, patient may present with easy fatigability, chest pain, syncope, and even sudden death. Arrhythmias may occur. Other symptoms would include severe cyanosis and infective endocarditis. An interventional procedure may be done, and this is by balloon valvuloplasty. Surgical treatment by valvotomy is called the Brock's procedure. Aortic stenosis is about 5% of congenital heart disease and is more common in males. This may be valvar, subvalvar, or supravalvar. Patients may be asymptomatic in mild aortic stenosis. With severe lesions, patient may have low cardiac output, congestive heart failure, syncope, and even sudden death. For aortic stenosis, a systolic ejection click may be heard at the left parasternal border. A harsh systolic ejection murmur may be heard at the right upper sternal border. A paradoxical splitting of the second heart sound may be heard. ECG may present with left ventricular hypertrophy with a strain pattern. Interventional procedure include balloon valvuloplasty, surgical valve replacement using porcine, homograph, or mechanical. Even a Ross procedure may be done, which is called the aortopulmonary translocation. Coarctation of the aorta occurs in 5 to 8% of congenital heart disease. This may be associated with bicuspid aortic valve, Turner syndrome. may be associated with mitral and aortic abnormalities, which is called Schoen complex. Patients with coarctation of the aorta may present with weakness or pain in the legs after exercise, arm-to-leg BP and pulse disparity, and systolic hypertension. Severe cases during infancy may present with severe heart failure, low cardiac output, and cyanosis. A short systolic murmur may be heard at the left parasternal border, radiating to the left interclavicular area and interscapular area. A chest X-ray of a patient with coarctation of the aorta may present with rib notching. The following are the diagrams that present the different types of repair, which include resection with end-to-end repair and patch aortoplasty. Other treatment for coarctation of the aorta would include percutaneous transcatheter interventions, and these include balloon angioplasty and stenting. The following are the list that comprises the cyanotic congenital heart diseases. The different lesions of cyanotic heart disease may be divided into the two different groups, those with increased pulmonary blood flow and those with decreased pulmonary blood flow. Cyanotic heart disease with decreased pulmonary blood flow include the following: Tetralogy of Fallot, pulmonary atresia with intact ventricular septum, tricuspid atresia, and total anomalous pulmonary venous connection with obstruction. The main defect of TOF would include a large ventricular septal defect, pulmonary stenosis, overriding of the aorta, right ventricular hypertrophy. Tetralogy of Fallot occurs in 10% of congenital heart disease. Main symptoms include cyanosis, which is often progressive. Patient may have dyspnea in exertion. They would have squatting. Death spells or hypercyanotic spells usually occur in the morning after crying, feeding, defecation, or on waking up. This diagram presents the pathophysiology of hypoxic spell. For the management of death spell or cyanotic spell, place the patient in a knee-chest position. Calm the patient, provide oxygen. Sedation may be given using morphine. For alleviating acidosis, sodium bicarbonate may be given. For severe cases, emergency surgery using a Blalock-Taussig shunt should be done. Prominent features for Tetralogy of Fallot include cyanosis, clubbing of the fingernails and toenails. A right ventricular tap or thrill at the left parasternal border may be heard, loud systolic ejection murmur at the mid-upper left sternal border, a single second heart sound. ECG may show right ventricular enlargement. A classical chest X-ray will show a boot-shaped heart with decreased pulmonary vascular markings. This patient has a classical clubbing of both fingernails and toenails, and the patient is seen squatting. This chest X-ray shows the classical boot-shaped heart due to right ventricular hypertrophy and decreased pulmonary vascular markings and a decreased main pulmonary artery. Patients who are untreated or unrepaired Tetralogy of Fallot will have progressive cyanosis, polycythemia, brain abscess, infective endocarditis, and right ventricular failure. Medical management include iron supplements for deficiency, phlebotomy. Propranolol may be given in prevention of death spells. Palliative surgical procedure includes Blay-Lactosig shunt or a central shunt, and definitive treatment is the repair of the Tetralogy of Fallot by closure of the VSD defect, infundibulectomy, and transannular patching. For cyanotic heart disease patients with increased pulmonary blood flow, they may be divided into two groups: those with abnormal ventricular arterial connections, and second, total mixing of systemic venous and pulmonary venous blood within the heart. Transposition of the great artery is the abnormal ventriculo-arterial connection, with the aorta arising from a morphological right ventricle and the pulmonary artery arising from the morphologically left ventricle. The pathophysiology of transposition of the great arteries occurs with two parallel circuits. Systemic venous return goes back to the right atrium, into the right ventricle, to the aorta, and brings back to the systemic circulation. On the other hand, oxygen-rich blood flow from the lungs goes back to the left atrium, to the left ventricle, pulmonary arteries, and back to the lungs. Survival depends on fetal pathways, patent foramen ovale, PDA, and a ventricular septal defect. This diagram shows the difference between the normal circulation and the circulation in transposition of the great arteries. Transposition of the great arteries comprises 5% of congenital heart disease, with male preponderance and with a history of maternal diabetes. Pathophysiology include aorta rising from the RV and the PA from the left ventricle, and this comprises parallel circulation. The following associated lesions include an atrial septal defect, ventricular septal defect, or patent ductus arteriosus. Shunting is necessary for survival for mixing of blood. Patients with transposition of the great arteries will be cyanotic at birth. Physical examination includes tachypnea with cyanosis, a single loud second heart sound. There may be an absence of a murmur, or a soft systolic murmur can be heard. ECG may be right ventricular hypertrophy or combined ventricular hypertrophy with the presence of a VSD, PDA, or pulmonary stenosis. The chest X-ray shows a classical egg-shaped heart, or the egg on its side, and this presents cardiomegaly with a narrow mediastinum. For unrepaired TGA, patients would have progressive hypoxia and acidosis. 90% mortality rate by 6 months if without any treatment. Those with a large shunt will be less cyanotic. Patients will eventually have the following: congestive heart failure and pulmonary vascular obstructive disease or infective endocarditis. Initial management of patients with TGA during the neonatal period would include prostaglandin infusion. This maintains the PDA patent. A balloon atrial septostomy may be done in order to maintain left to right shunting, in order to maintain mixing of blood. Patients with congestive heart failure should be given proper heart failure medications. Definitive management includes the arterial switch or the Giattini procedure. For those with delayed treatment, atrial switch may be done through Senning or Mustard procedure. Cyanotic lesions with total mixing include the following: a common atrium or ventricle, total anomalous pulmonary venous return, and truncus arteriosus. Patients with total anomalous pulmonary venous recur occurs in about 1 to 2% of congenital heart defects. There is no direct communication existing between the pulmonary veins and the left atrium, and the following defect may be divided into 4 types. Connection may be done in the supracardiac area, directly to the heart, infracardiac, or mixed type. This diagram shows the pulmonary veins that drain below the diaphragm, and is usually obstructed. The patients would have a huge atrial septal defect. For patients without pulmonary venous obstruction, patients will present with congestive heart failure, growth retardation, and frequent lower respiratory tract infection. Patients may have mild cyanosis from birth, a precordial bulge with hyperactive right ventricle. The second heart sound is wide, split, and fixed. The second heart sound is accentuated. A grade 2 to 3 systolic ejection murmur may be heard at the upper left sternal border. Patients with total anomalous pulmonary venous return will have an ECG with right atrial enlargement and right ventricular hypertrophy. Chest X-ray will show moderate to marked cardiomegaly with increased pulmonary vascular markings. A classical snowman sign or figure of 8 may be seen in supracardiac type. Clinical picture varies with age depending on the level of pulmonary vascular resistance. During the newborn period, signs of heart failure are usually absent. They may have minimal cyanosis. For older infants, pulmonary blood flow is increased and the clinical picture is dominated by heart failure. Truncus arteriosus. This diagram shows the different types of truncus arteriosus depending on the morphology of the pulmonary artery. An ECG of a patient with truncus arteriosus will present with combined ventricular hypertrophy. Chest X-ray will show cardiomegaly with increased pulmonary vascular markings. A right-sided arc may be seen in 30% of patients. 2D echocardiogram demonstrates a large truncal artery overriding a large ventricular septal defect. This diagram shows a type 2 truncus arteriosus, with the pulmonary arteries arising from the aorta. The truncal valve may be quadricuspid, stenotic, or may have insufficiency, and usually overrides a large ventricular septal defect. In summary, congenital heart diseases may subdivided into left to right shunts, occurring 40%, obstructive lesions, occurring 25% of the time, and cyanotic heart diseases, comprising 20%. Thank you for your utmost focus and attention. Please answer the post test. All for the Filipino child. Happy Valentine's.